Today we are going to discuss the post-infectious glomerulonephritis or infection-related glomerulonephritis. The post-infectious glomerulonephritis or infection-related glomerulonephritis is very much uncommon in developed world. But if we talk about the prototype of the disease is the post-streptococcal glomerulonephritis, and the post-streptococcal glomerulonephritis is very much common in children. And basically what happens when we discuss about the post-infectious glomerulonephritis, formally implies the antecedent infection and the latent period of days to weeks after infection is cleared. So 10 to 14 days of the post-streptococcal glomerulonephritis. Particularly for the adults with non-streptococcal infection, glomerulonephritis occurs during ongoing infection. Thus preferred term is the post-infectious glomerulonephritis. And the most common organism is Streptococcus and Staphylococcus. And if we talk about the gram-negative bacteria, the most common bacteria are the Pseudomonas and Escherichia, and the Yersinia may be the responsible for the post-infectious glomerulonephritis. So this is the post-infectious glomerulonephritis we are discussing, and the prototype of the disease is the post-streptococcal glomerulonephritis. Now we talk about the pathogenesis. The pathogenesis, if we talk about the disease, actually nephrogenic two streptococcal antigens are responsible for the disease. The number one antigen is the streptococcal pyrogenic exotoxin B. Streptococcal pyrogenic exotoxin B is responsible. Number two is the plasmin receptor. Which we also call the glyceraldehyde phosphate dehydrogenase. So two nephrogenic antigens are responsible for the disease. One is the streptococcal pyrogenic exotoxin B, and the second is the plasmin receptor, which we call the glyceraldehyde phosphate dehydrogenase. Basically, these are implicated in the development of the post-streptococcal glomerulonephritis. What happens? The immunocomplexes in situ or formed in circulation induces complement activation. Alternative complement pathway are activated. What happens when immunocomplexes are formed in situ or are formed in circulation, and these are responsible for the activation of the complements and coagulation pathway and leads to the recruitment of the neutrophil to the glomeruli. So this is the brief about the pathogenesis. So if we discuss about the pathogenesis, two nephrogenic antigens are responsible. One is the streptococcal pyrogenic exotoxin B, and the second is the plasmin receptor. The plasmin receptor, which also called the glyceraldehyde phosphate dehydrogenase, and the plasmin receptor are implicated in the development of the post-streptococcal glomerulonephritis. So we are discussing the pathogenesis of the disease. In terms of the pathogenesis of the disease, basically two nephrogenic antigens are responsible, and these two nephrogenic antigens are number one streptococcal pyrogenic exotoxin B, and the second is the plasmin receptor. These two nephrogenic antigens are responsible for the disease or development of the post-streptococcal glomerulonephritis. What happens? The immunocomplexes are formed, and these immunocomplexes either in situ formed or are trapped from the circulation, and the activation of the complement pathway, the alternate pathway of the complement is activated, and when this is activated, there is the recruitment of the neutrophil to the glomeruli. So this is about the pathogenesis of the infection-related glomerulonephritis. Now we discuss the pathology. Actually, the pathology, if we do the kidney biopsy and see the pathology of the disease, and when we see the light microscopy, what we see the diffuse endocapillary proliferative glomerulonephritis. In light microscopy, we see the diffuse endocapillary proliferative glomerulonephritis with intracapillary neutrophils. When we see the light microscopy, there is diffuse endocapillary proliferative glomerulonephritis with intracapillary neutrophils. Intracapillary neutrophils. So these are the light microscopy finding of the disease. If we see the immunofluorescence, so the glomerular basement membrane becomes granular. Glomerular basement membrane becomes granular with C3 dominance. With C3 and immunoglobulin dominance. And gives the starry eye appearance in immunofluorescence. So we have done the kidney biopsy. In kidney biopsy, we have seen the light microscopy, we have seen the immunofluorescence. And if we see the electron microscopy, in electron microscopy, we see the large scattered subepithelial electron dense deposits. Large scattered subepithelial electron dense deposit, which we call humps. So this is about the pathology of the disease. So we are discussing the infection related glomerulonephritis. So infection related glomerulonephritis, the second name is the post infectious glomerulonephritis, and this is the prototype of the post streptococcal glomerulonephritis. So when we talk about the post streptococcal glomerulonephritis, this is very common in children, and the post infectious glomerulonephritis is usually not seen in developed countries or developed world. What happens? The most common organism responsible for the disease are streptococcus or staphylococcus, and the organisms can come from the pharyngitis, pharyngeal infection, or the skin infection. Other gram-negative bacteria which are responsible for the disease are the E. coli, Pseudomonas, and Yersinia can be responsible for the disease or post-infectious glomerulonephritis. Usually, immunocomplexes are formed in situ. Or these immunocomplexes are formed outside and are trapped in the glomeruli and are responsible for the disease. If we talk about the pathology, so we do the kidney biopsy, and in kidney biopsy we see the light microscopy. There is diffuse endocapillary proliferative glomerulonephritis with intracapillary neutrophils. So intracapillary neutrophils. And if we see the immunofluorescence, in immunofluorescence, there is the granular glomerular basement membrane, GBM, with C3 and Ig immunoglobulins dominance, which give the starry eye appearance. If we see the electron microscopy, the large scattered subepithelial electron dense deposit, which we call the humps, we usually see in infection related glomerulonephritis or post infectious glomerulonephritis. So now, after finishing the pathogenesis and pathology, we come to the next part of the disease and the clinical features. What we see usually, what we find, how the patient presents. Usually the patient presents with the RPGN, rapidly progressive glomerulonephritis. The patient presents with the RPGN. There may be the hematuria, proteinuria, there may be the edema, and the color of the urine may be the dark, or there may be the hematuria. So this is the presentation usually, and with history of the pharyngitis, cellulitis, pneumonia, maybe there is the history. So this is the clinical feature usually the patient present with. So clinical feature, the history, when we take the history, there may be the history of the pharyngitis, there may be the history of cellulitis, there may be the history of pneumonia, and with all this background, the patient may present with the rapidly progressive glomerulonephritis, which we call the RPGN, and beside this, there may be the dark color of the urine or hematuria, there may be the edema. So, or there may be the proteinuria. So these are the clinical features usually we see in the post-streptococcal glomerulonephritis. Actually, when we do the labs, when we do the investigations, what we found, if there is the RPGN, there is the increased rise of the creatinine, and the rapid rise of the creatinine there may be. And if we do the complements, if we do the serum complements, and we find the decreased CH50, low CH50s, and the C3, in 90% of the cases, usually C3 is low. Rarely C4 is low, but mainly the C3 is low, and there may be the increased ASO titers, and there may be the red cell cast in the urine, there may be the proteinuria, there may be the RBCs, so there may be the nephritic picture of the urine. So if we do the labs, we may find the nephritic picture of the urine. There may be the features of the RBGN, like the rapid rise of the creatinine and urea. And if we do the complements may be low CH50, and especially the low C3 levels, and rarely C4 may be the low. So these are the labs, And these are the investigation which we usually do in infection related glomerulonephritis. Now, what is the treatment? Usually the treatment is supportive. And we are supposed to take care of the AKI, we are supposed to take care of the hypertension, we are supposed to take care of the edema. So we are supposed to take care of these complications, and mainly the treatment is the supportive, but we are supposed to remove the causative organs. We are supposed to do the elimination of the ongoing infection. Like we are supposed to treat the infection with the antibiotics. Like although there is evidence, there is no role of the antibiotic, and there is less evidence of the use of the antibiotics, but we are supposed to treat the ongoing infection. If the infection is ongoing, then we are supposed to treat it. Basically, if we talk about the immunosuppression, there is no clear role of the immunosuppression. Actually, in children, the recovery is between 2 to 3 weeks. In children, usually the recovery comes in 2 to 3 weeks. But one more thing is important regarding the post-infectious glomerulonephritis. We are supposed to rule out the C3 glomerulopathy. If the C3 is low, as we said, in 90% of the cases, the complement 3 level is low. So if C3 is low, then we are supposed to rule out the C3 glomerulopathy. So this is the brief about the post-infectious glomerulonephritis or infections related glomerulonephritis. Thank you.